Honorable Chairman, dear colleagues, thanks for this nice and long introduction. It is a great pleasure to be here, and I'd like to start with thanking to the organizing committee for giving me the opportunity to visit India once again, and thanks to Dr. Allah Badia. So, Dr. Seidman has made my life easier with giving the previous talk, so I will be able to skip a lot of stuff to save your time and to prevent you getting bored. And I'll try to give you a critical look at the long-acting FSH in the next 20-25 minutes. And I recently changed jobs, moved to the American Hospital of Istanbul. So as this presentation is about a particular pharmaceutical product, I would like to start with declaring that I have no conflict of interest associated with this presentation. I've just received some educational grants in the past, including the manufacturer, but also from other companies and societies as well. So I was interested in this molecule as early as, I would say, 2010. That was when we published this review. And I wasn't as lucky as Professor Blockeel to put my hands on it and try when it was in development. But now we've been using it for a while, and I'll share my experience. So I'll skip these parts. It is Dr. Seidman told you how it is produced and what it does eventually. It is, after one shot, it reaches maximal levels after like 48 hours, and it maintains serum FSH levels above the therapeutic threshold, which would be something like 1.1 nanograms per ml for an entire week. So the pharmacokinetics is different from recombinant FSH or endogenous FSH. Okay. So how does it translate into clinical practice? Why are we talking about this? This may enable you to cut down, actually, you would think 6 injections during the stimulation, but it would enable you to cut 5 injections. We'll talk into detail. We'll talk about that later on. But I have to tell you, I truly admire the molecule and the idea behind it. People put a lot of effort and work on it. So it's been in development for a long time, and it wasn't only the novel idea and the technology of production, but they meticulously tested it with all phases of trials. Initial trials were done in hypogonadotropic hypogonadism men. The idea was if this new designer's molecule was immunogenic and induced formation of antibodies against it, against FSH, and if you give it to a normal person, then these newly forming antibodies could have neutralized her or his endogenous FSH, rendering him hypogonadotropic. So that's how they started. It's all, very good line of thinking, very nice trials. Then they started using it on all contraceptive suppressed women. Then they did, feasibility studies, dose finding studies, developed a totally new method of dose finding. And then they did actually the largest trial in the field of IVF until today, the ENGAGE trial, which we'll get into details. Followed it up with different patient profiles. PURSUE is about to be published in a few months. It includes older women. And they also systematically followed the children born after stimulation with corifoliotropin to see if congenital anomalies and other problems were increased. So let's look at, this, I'll just keep it short, just highlight a few things that I want to discuss later on. These are the clinical trials. So what is essentially done is, they recruited women, usually younger than 36, excluded underweight women as well as obese women, recurrent implantation failures, recurrent pregnancy losses, smokers, potential over-responders, and potential or known poor responders. As we wouldn't be able to withdraw the medication. And it is also shown in the pharmacokinetic studies that the response to Elonva is kind of, stable across the dose range. You cannot increase the amount of stimulation by changing the dosage later on. So it provides the maximal response from the available antral follicles. So that's why they excluded hyper responders, and as they had no data on poor responders, they didn't want to include them as well. So they followed up. If the patients needed additional stimulation after the end of the first week, they followed up with daily recombinant FSH injections in this population. So when I pull up these trials altogether, clinical ones, okay, what happens is the number of oocytes collected compared to daily recombinant FSH stimulation is significantly increased consistently by an average of 1 oocyte. Actually, it's not too much, but it is not lower. Okay. And the pregnancy rates, ongoing pregnancy rates, are not decreased, but they're not increased on the other hand. So you can save a few injections and maybe collect one more egg and maintain similar pregnancy rates with this product. So this is the largest trial, ENGAGE trial, recruiting women under 36, normal weight or just overweight but not obese. And they were over 60 kilograms. That's the common patient that you would see. What happens is, as you see, the pregnancy rates are almost identical. It's a very convincing study in this regard. But this is the other study, which is called the ESHRE study, which recruited only women who were under 60 kilograms. So after all these pharmacokinetic and pharmacodynamic studies, the manufacturer decided that the appropriate dosage should be determined according to patient's weight. And they said if the patient is less than 60 kilograms of weight, regardless of BMI or age, etc., the ideal dosage is 100 micrograms. And if the patient is over 60 kilograms, the ideal dosage is 150 micrograms. So the previous trial was in women over 60 kilograms, and they were given 150 micrograms. This trial, ESHRE trial, recruited women under 60 kilograms, and they were given 100 micrograms alone. So what happened is if you look at the pregnancy rates and the pregnancy rates, right-hand side is recombinant FSH daily injections, left-hand side is corifoliotropin, Elonva. You see there is actually what I would call a clinically significant difference. It's like almost 10% decrease in the corifoliotropin group. And it is really nicely stated in the article. It's not statistically significant at 5% level, which is something we are just arbitrarily define. And when you calculate, actually the p-value is 0.06. Okay, so this is the first question in my mind when I first came across Elonva. I wasn't as convinced as I was convinced for the 150 micrograms for patients weighing over 60 kilograms. In this patient group, I have doubts if this works equally well, and I think it needs to be determined further on. Okay. So this is the TRUST trial. What they did, as this is a new molecule which could have been immunogenic, though that was excluded in prior studies, they wanted to see if it performed same across repeated treatment cycles. And so they examined women who underwent like 2 or 3 cycles with Elonva. So it seems to be performing consistently across repeated cycles. The oocyte yield is similar, and as expected with repeated cycles, pregnancy rates are decreased, but that has got nothing to do with the medication itself. So it is okay to use it in subsequent cycles of the same patient. As discussed, once you inject it, you can't withdraw it, and it provides maximal stimulation in the suggested dose range. So there could be a concern about ovarian hyperstimulation syndrome. And actually, the review, which was published in Fertility Sterility, suggested it could have been increased, but when it's properly analyzed, the data is properly analyzed, the ovarian hyperstimulation syndrome is not increased when you use Elonva in the suggested dose range compared to like 200 units daily recombinant FSH injection in the same patient group. And neonatal and fetal safety data is followed up by Michel Bonduel, who does a lot of work in this field, and the incidence of major congenital abnormalities or the neonatal outcomes are not deteriorated, are not worse with this molecule. Okay? So to sum up the first part, okay, I agree with Dr. Seidman. It works, it functions as intended. Okay? It seems to be safe. It provides you with a similar number or slightly higher number of oocytes. I have my reservations for patients weighing less than 60 kilograms and 100 micrograms dosage. It's not immunogenic, and there's no apparent increase in congenital abnormalities. And 1/3 of your patients would reach HCG criteria with single injection of this new product. However, although this sounds nice, this data is coming from ENGAGE trial. So this is, you inject the patient with Elonva on day 2 or day 3. So you scan her again 7 days later, and you do the monitoring. And 1/3 of patients meet the HCG criteria. In the other arm, where patients were stimulated with recombinant HCG, recombinant FSH daily injections, on the same day, actually 42% of patients had already met the HCG criteria. Okay, so it's not a huge difference. I don't regard it as an advantage, but it sounds nice. 1/3 of your patients would just meet HCG criteria, with just one injection. Okay, so that is totally fine. It sounds exciting. So what happens in Turkey, as I don't have price information for every single country, okay, I would certainly use it more often if it was at the same cost. Okay, so in Turkey, 100 micrograms is 1,400 liras, 150 micrograms is 1,500 liras. Okay, so this is something like $700 on the right hand side, and 650 in the 400 micrograms. If you calculate the cost of a stimulation cycle, either based on the data reported in the ENGAGE trial, regular patients, so average gonadotropin consumption with Elonva or recombinant FSH, which would be Puragon in this case. Okay, so the cost of overall cycle with Elonva is 2,200 in Turkish liras, and the cost of, if you do the same cycle with Puragon and Orgalutran, the cost is almost half. Okay, and if you go for menotrophins actually, rather than recombinant FSH, the cost is even less. Okay, so that is what happens in Turkey. It could be the same price in India. I don't know. It could be, even cheaper in some countries. I have no idea. But cost is an important thing to consider when we pick up our medications. Okay, so my question in my setting is, why should I pay, or why my patient should pay more for something that doesn't claim to improve my clinical results, but just provide the same results with a few less injections? Okay. So should I pay more to prevent patient dropouts? This is one of the reasons, okay, which is frequently mentioned in the company's presentations. So you all know, psychological burden is important in maintaining patients in subsequent treatment cycles. And as shown by Dr. Seidman and Professor Blockeel yesterday, compared to the long protocol, which involves a lot of injections and 2 embryo transfers, if you switch to an antagonist protocol, less injections and a mild stimulation and a single embryo transfer, you can maintain a higher proportion of patients in treatment. Okay? However, is this due to the number of decreased injections, the decreased number of injections, or a different mindset provided for the patient by your consultation in the beginning of cycle? We'll give you mild stimulation, you'll have 1 embryo transfer, the chances is, mild, but it's not hard on you, you can try it again. So it could be a different mindset. Let's see how important is the number of injections on patients' perception of an IVF treatment. This is a prospective trial, prospective study, it's not a trial, published by the Boston IVF group, Alice Domar, who has done a lot of work on psychological aspects of ART treatment. They specifically looked at patients who had full insurance coverage for ART treatment, so who would pay no money out of pocket, so they were entitled to the next treatment cycles free, okay, but they were still dropping out. So they followed up these people, they asked, what are the reasons for dropping out? Yes, psychological burden, the toll on relationship is important, but the patient, that's the conclusion. The least likely reason is I couldn't withstand all the injections, so maybe number of injections is not that important really. Okay, there should be another reason to use, if you're paying more, maybe there should be another reason to use this product. Okay, so what are we cutting? Saying that it's effective for 7 days doesn't mean actually you're cutting 6 injections. Actually, you're cutting 5 injections, because normally in a fixed antagonist cycle, you would start GnRH antagonist on the 6th day of stimulation. If you're using Elonva, you're supposed to start on the 5th day. Okay, so basically, if you were doing, with daily recombinant FSH, you wouldn't have this injection on the 5th day. This comes from observations in these trials, because in the feasibility trial, when they started on day 6, 16% of the patients had a premature LH surge before GnRH antagonist. And that's why it was decided to move it to day 5. And even with day 5, if you look at ENGAGE trial, the incidence of premature LH surge were decreased by half, but it is still significantly higher than daily recombinant FSH injections. Okay, so how much does this affect the clinical outcome? It is, a controversial issue, and we have already been shown by this large study that the clinical outcome is not significantly changed. Okay, however, there could be certain small percentage of patients, who would have these premature LH surge, and their personal results might be, maybe adversely affected. So what is the option? What can we do? If you want to cut more injections, Okay? So as Dr. Blockeel presented yesterday, maybe we should make more use of the endogenous FSH. It wouldn't start, substantially decreasing until day 5 anyways. So rather than putting the patient on Elonva on day 2, maybe we can put her on, we can give her the injection on day 4 and save 2 more days. So what would happen, and they did a small randomized trial to see, so as it's a randomized trial, the patient's baseline characteristics are similar. And what happened is, the total FSH consumption, additional FSH consumption after Elonva is significantly decreased, but the number of GnRH antagonist injections is significantly increased because you're actually elongating the follicular phase, with starting it later on, and Elonva will be effective for 7 days anyways. And interestingly, a higher percentage of patients, almost 1/3 of the patients, were deemed to be at risk of ovarian hyperstimulation, and they were given the agonist injection. Though, the syndrome itself can be mostly avoided, but still it is worrisome. And the pregnancy rates were not significantly different, but again, I would say, this is a small size randomized trial, and there is a kind of large gap between the actual figures observed in the 2 arms. So that needs to be confirmed in a larger trial, but given this data, maybe that's not the best way to go. If it is exactly replicated in a larger sample, it might be associated with maybe decreased pregnancy rates or increased treatment costs. And another thing to look at, this is just an idea, how important is cutting 5 injections. You may be aware that a company has recently developed the progesterone in an aqueous solution of progesterone. It's not in progesterone in oil, so it can be given as subcutaneous injections. And in a large trial, it's been shown to be as effective as vaginal progesterone. Okay, so we may be in the close future, perhaps, depending on patients' choices and costs again, switching to daily subcutaneous progesterone injections if patients find it more tolerable than taking several vaginal tablets every day. We may be switching to daily progesterone injections for the luteal phase, which would mean a lot of injections actually. Okay, like you will have an injection for at least 2 weeks. So in that scenario, cutting down just 5 injections maybe wouldn't be that important. Okay, that's something, just an idea. I think, as I said, what is more stressful for the patient remains to be determined. Maybe it's not the injections. Okay, it could depend on cultural differences. It could depend on your working conditions. Okay, in private practice in Istanbul, patients love to see their doctors. If you allow them, they would come every day, which is not what we want. Okay, and I'm usually in favor of actually milder treatments. Less frequent visits to the clinic, less ultrasound scans, etc. And when I was working in a public hospital, when I was running the public unit, I would put the patient on the antagonist. I would, regular normal responder patient. I would call her back on day 8, after already starting antagonist to do the first scan. Okay. However, when you go to private practice, if you actually call the patient a week later, patient is getting, why am I not going every other day, etc. So, you need to take these things into attention as well, but from just a purely biological standpoint, it is best if they come less often. It's easier for the working class patients, etc. And patients, as Dr. Seidman mentioned, as shown in this study in oocyte donors, okay, they find this cortifolitropin injection more convenient than daily recombinant FSH injections. Okay, I think what I would pay more money, for is to ensure that my patients make less mistakes with their injections. I think that's the most important indication. Okay, so according to the study, yes, 55% of patients, they say they don't like the injections, but importantly, almost 60% have trouble with giving these injections to themselves, even though they are, simple subcutaneous injections. They have been taught in person by a nurse. There are videos available in the internet. There's, detailed instruction sheets, etc. Still, 60% of patients have trouble with it. Almost half of them make a mistake at some point, and 1/3 of these patients don't tell you that they made a mistake. Okay, so here's a collection of my personal experience with my patients. I prescribed, some patients Gonalev 450 flacon, which actually, includes 600 units. Despite detailed, directives, the patient injected 225 every day and threw the flacon away. Okay, So she lost a lot of gonadotropin. She increased her treatment cost more than Elonva. Okay, so probably Elonva would be best for this patient. Or, not all the patients are, comfortable with giving self-injections, and they don't have the opportunity to come to your clinic every day. So you give them the description, you give them the prescription, and they go to a close-by clinic to have their daily injections. And not all the nurses, not all the doctors are experienced with gonadotropins, okay? Sometimes the medical personnel gives them the wrong injection. And, they end up in losing their medication or getting the wrong dosages, okay? So I had a patient who was actually a patient with polycystic ovarian syndrome. That's why I prescribed her the recombinant FSH pen, which enables you, more precisely, tailor the dosage. And she injected all of it at once on the first day. Okay, so we stopped the injections. She had a proper stimulation later on, and she even conceived. But assume that this happened towards the end of an IVF cycle. For a patient who was under risk of ovarian hyperstimulation. Okay? They can do everything. I had another patient with polycystic ovarian syndrome who somehow managed to inject 12 units a day rather than 112 with the syringes. Okay, so they did, or another patient put all of his medication to the deep freeze. Okay, so, practically killed the medication. Okay, so they do all these things, and I would prefer to have 100% control over the injections myself rather than leaving it to the patient. Okay, so this could be a good indication for Elonva. Okay, so but if you think in a broader perspective, this is a minority of patients. But that wouldn't be the reason to switch to long-acting FSH for all your patients. But I find this as the most important, advantage of long-acting FSH. So in summary, okay, so the advantages is I am truly convinced that it is as effective as daily recombinant FSH injections when you give 150 micrograms to a woman weighing over 60 kilograms. And although there is no upper weight limit mentioned, if you look at, in detail in the pharmacokinetic studies, I wouldn't probably personally use it for a patient who weighs more than 85 kilograms, 85 to 90. Okay, then they would fall below the therapeutic threshold earlier than 7 days. Okay, but that's a minority of patients, and that would decrease injection errors. The disadvantages, I would say, is price. In my setting, I read in one paper it's the same price, it's the same cost in Denmark with recombinant FSH. If that's the case, I would use it more often. You should look at your own context. It will require adaptation on your part as well when they ask doctors if they want to adjust the dosage in the ENGAGE trial, because it was a double dummy trial. Both patients had an injection in the beginning, and then they were having daily injections, placebo for recombinant FSH as well. And doctors felt the need to decrease the dosage more often in patients who received Elonva plus placebo for recombinant FSH. Okay, so it provides a stronger stimulation initially. So you'll need to get used to it. There would be a learning curve, so you should take that into consideration when you start switching. I would say effectiveness of 100 micrograms dosage, as suggested by the manufacturer in patients weighing less than 60 kilograms, is doubtful. Okay. And there's no convincing data at the moment for poor responders and hyper responders, and luckily poor responders will be mentioned in more detail in the following speech. Though congenital anomaly data is reassuring and FSH is, in any form is unlikely to be teratogenic, there is still limited data, but I'm not worried about that. And it is equivocal whether this decreases stress. So that was my conclusion slide when I gave this speech a few months ago in another place. That was before July. What happened in July? At the ESHRE meeting, there were 2 important presentations about corifoliatropin. The first one was given actually by an employee of the manufacturing company, MSD. And based on the PURSUE trial data, which recruited women over 36 years old, and they were giving 150 micrograms. The study mainly was done in the US. So they were giving 150 micrograms to women weighing more than 50 kilograms. Okay, when they looked at the data, actually they decided that the company decided that if a woman is over 37 years old and if she weighs more than 50 kilograms, so you should give 150 micrograms. even if she is 59, 58, 55 kilograms, less than 60. So this brings a new thing into attention. The dosage maybe is not only based on weight, but you should also take into consideration patient's age. So this will be probably more discussed in more detail in the next presentation. But there was a small size randomized controlled trial suggesting Elonva is as effective in poor responders as well. Okay, so I want to conclude with my idea of an ideal stimulation. Okay, so what would happen is I would use long-acting FSH. So the patient would come to the clinic, we would do the scan, make sure that she doesn't have any cyst, give the injection, and she goes away. Nobody's worried. Okay, so probably that would be nice if we could switch to, like the early days, to a single injection of GnRH antagonists. Okay, like, which would be effective for a few days as well. But the most important thing for me, if a company came up with something called delayed action HCG. Okay, that's where we have the most problems with patient errors. Let's say you schedule a collection for, 9 a.m. in 2 days later, and the patient is supposed to give herself the HCG injection at 9 p.m. tonight. Okay, you might have all came across such things. The patient, falls asleep, forgets it totally. Then, she wakes up at 3 a.m. and, gives the injection at 3 a.m., messes up all your schedule. You have to do the collection. I remember doing collections at 3 a.m. because of patient mistakes. Okay, so I would prefer if there's something called the delayed action HCG. The patients come to the clinic, you do the scan, you decide that she's supposed to take HCG that day. You would give it in the morning under direct supervision, but it wouldn't be effective, like after a certain period, like 10 hours later or 12 hours later, whatever. So that would really prevent patient mistakes, and in combination with this long-acting FSH, that would be nice. You can even combine this with this recently presented technology of, tablet attached ultrasound. They can do their scans, they just come for the injections, and that will be all. Okay, so thanks for your attention. I hope I'm on time and didn't bore you with, the same, more or less the same subject.